Good morning. Today we'll have another subject regarding the GI tract, which is amoebiasis, which is a very important subject, especially in the Middle East. الإصابة بالأميبا. The learning objectives to understand the difference between Entamoeba histolytica, which is our subject today, and other types of amoeba, especially from laboratory point of view, how we identify, how we differentiate between them. Entamoeba histolytica has intestinal and extra-intestinal infection, and we are going to study this. For example, in the liver, also we can have hepatic abscess. We study the epidemiology, pathogenesis, pathology, immunity against amoebiasis. Also, we have to recognize the clinical manifestation and the treatment and the prevention of, not in details. The amoebas, their movement is by pseudopoda, الأرجل الكاذبة. Pseudopoda, الأرجل الكاذبة by simple وتنشطر إلى اثنين. They can produce spore-like just to prolong their survival. الأميبا من تشوف الظروف غير مؤاتية تتحول من تروفوزويت إلى سيست. من الظروف ملائمة water temperature إلى آخره يتحول السيست إلى التروفوزويت. Amoeba of a human clinical importance. As we said, Entamoeba, first of all, Entamoeba histolytica, which is pathogenic. Other types of amoebas, Indolimax. It's amoeba, but GI commensal, not pathogenic. Iodamoeba, also GI commensal. So Indolimax and Iodamoeba are GI commensals, which we are not concerned with them. Just in case to differentiate between them according to their size, morphology, nuclear characteristic. We are going to depend on the nuclear characteristic to differentiate between these different. Let us go. The species that we are concerned Entamoeba histolytica. Let us go to Entamoeba in general. Entamoeba as a genus is the pathogenic. Could be Entamoeba dispar. Entamoeba dispar is and commonly in the lab they cannot differentiate between Entamoeba histolytica and Entamoeba dispar, except with the presence of RBC in Entamoeba histolytica inside the trophozoite, while Entamoeba dispar has no RBC, no ingested RBC, because Entamoeba dispar also can be present in the intestine. Again, another one, Entamoeba hartmanni and Entamoeba coli. These are all Entamoeba. You should be aware we have started with Entamoeba, and there are other genera, Indolimax and Iodamoeba. We are not concerned about them today. The following notes and table, how we are going to differentiate between these different types of Entamoeba according to their size, as I said, morphology, and the nuclear characteristic. Very important, the nuclear characteristic, and we are going to speak about that. Entamoeba dispar, which is commensal, is very similar to Entamoeba histolytica, as I said, but it shows no ingested RBC. Okay? Now, how to differentiate between, just 1 minute if you excuse me. Sorry for the interruption. How we to differentiate between the characteristic of different species of entamoeba? These are the characteristics. These are entamoeba histolytica, entamoeba hartmanni, entamoeba E. coli. The most important differentiation is between E. coli and entamoeba histolytica. E. coli entamoeba, here E. coli, not Escherichia. Here we are talking about E. coli, entamoeba coli, and entamoeba histolytica. Cytoplasm, cytoplasm, it has ectoplasm, endoplasm. Cytoplasm is بالهيستوليتيكا differentiation undifferentiated، يعني تميز الاكتوبلازم من الاندوبلازم. لو ناخذ النيوكليوس هسه، صفات النيوكليوس، peripheral كروماتين، نشوف البريفرال كروماتين راح نشوفه بالصوره بعد شوي. fine coarse irregular بالايكولاي. كاريوسوم small central large eccentric على طرف الكاريوسوم. ingested RBC او ingested particles. بكتيريا no ingested bacteria بالهيستولوتيكا. E. coli, yes, there are ingested bacteria. RBC, yes, present in histolytica, not present in E. coli. Very important point these are. The size almost the same. Cyst, regarding the nuclei of the cyst, 1 to 4, 1 to 8. النيوكلياي تبع الإي كولاي بالسيست كروماتويد بودي روتس راح نشوفها سبلنتر، هيك شظايا سبلنتر كأنما خطوط. The size of the cyst more than 10 micrometers, and here is also more than 10. We will see it and differentiate between them. This is the cyst of Entamoeba histolytica 4, right? And these are the chromatoid body. And we said that the chromatoid body are rods. And فعلا أنهم على شكل رود. This is the trophozoid. You can see the you can sorry. You can see here the cyst with this chromatoid body. The trophozoid, these are the pseudopod, الأرجل الكاذبة. These are ectoplasm, part of the ectoplasm. The endoplasm is the inside. So we can differentiate between the ectoplasm and endoplasm. And we said it contains ingested RBC. These are ingested RBC. This is the nucleus. This is the central karyosome. The chromatin around the nucleus fine and regular. And this is real stain. You can see that the RBC inside the Entamoeba histolytica trophozoid. And these are very characteristic. This is the nucleus, central karyosome, fine peripheral chromatin bodies. The cyst of Entamoeba histolytica, 4 nuclei, a glycogen inside it. And this is the glycogen vacuole, which we can stain it by iodine. That is why for stool examination, we do wet preparation staining by normal saline. Just we put a drop of normal saline and the stool and cover slip, or we use with it iodine stain just to see whether the glycogen is present in the cyst or not. You know, glycogen can be stained by iodine. You know this basic chemical reaction. In Entamoeba coli, you can see that the nuclei are many in the cyst. We call them octonucleated. Octo يعني 8. زي ما نقول tetra, hexa. Octo, it means 8. And the chromatoid bodies are splinter. You can see them. Splinter. شظايا هيك خطوط. The trophozoid containing ingested bacteria, no RBC ingested. This is the nucleus, the karyosome peripheral, the chromatin thick and irregular around the nucleus. So we start with Entamoeba histolytica. They can cause diarrhea and amoebic dysentery. What is dysentery, amoebic dysentery? Amoebic dysentery means blood and pus and the mucus. So one of the causes of dysentery is amoebic dysentery. We may get extra-intestinal infection, as I said, in the liver, transmission, fecal-oral route, reservoir only human. So it's a human parasite. Where the infection occur in the colon. Where in the colon? Mainly in the cecum and rectosigmoid. This parasite is facultative anaerobe protozoa. This is a protozoa. Entamoeba histolytica is a protozoa. The morphology of the trophozoid and cyst, we can differentiate, as we said, between ectoplasm and endoplasm. The nucleus has central karyosome, fine regular granules around them, contain ingested RBC. The cysts have 4 nuclei, glycogen vacuole, which can be stained by iodine. It has also 1 to 2 chromatoid body, cigar shaped, and we have seen that chromatoid. A clinical capsule, and we always say clinical capsule is very important. Amoebiasis is, generally speaking, is asymptomatic. Many people are infected and they don't know, and may produce intermittent diarrhea with abdominal pain. Especially the diarrhea sometimes come as diarrhea and sometimes as constipation. Diarrhea, constipation, you have to suspect amoebiasis. Occasionally, severe dysentery, you get abdominal cramp, abdominal pain, high fever, and the colonic mucosa is typically invaded, and you can see multiple ulcers on the colon. And due to perforation of the colonic mucosa, the amoeba may reach to the liver and produce hepatic abscess. Hepatic amoebic abscess. عفوا. The clinical picture of amoebiasis. Let us go further. Epidemiology, amoebiasis is worldwide, higher in warmer countries, Middle East, warmer country. Normal people harbor entamoeba dispar, so we have to differentiate between entamoeba histolytica and entamoeba dispar, and we mentioned that. The cyst of entamoeba resist chlorination quite a lot, can resist heating 55 degrees centigrade, and can resist gastric juice. That is why it can escape and go down to the colon. Immunocompromised individual more susceptible. And most infected individuals are symptom-free, asymptomatic, we said. Most people infected with Entamoeba histolytica are asymptomatic. Pathogenesis, we say that this parasite has the capability of invasiveness, can cause ulcers. From the ulcers can invade the intestine, the colon, and then it goes to the extraintestinal tissues. They have a proteinases, which can activate complement and break down collagen. This parasite has cystinoproteinase, which assists in the extracellular spread. By lectin, by a substance called lectin, they can adhere to the mucosa of the colon, have the capacity to lyse host cells. They can invade the cells and destroy them. With the capabilities of entamoeba, the microflora, which are present in the intestine, also assist in the invasiveness by increasing the ulcers, increasing the infection of the ulcers, which make the ulcers more friable, أكثر ليونة for invasiveness. In the lesion, early you get a neutrophil and cytokine release, and these cytokines either are protective or can, there will be little mucosal inflammation, but ulcers are present. The ulcers are described sometimes like a flask-like, زي الدورق, extend in the submucosa. Secondary bacterial infection, as I said, also could happen with these ulcers. Lead to granuloma, this, which is present in 1%. Amoeboma is collection between granulation tissue, fibrosis, infection, and these are all collected together and form amoeboma. The abscess formation may reach to the liver, may reach to the lung, may reach to the brain. If they go through the blood stream, أقرب مكان هي الليفر. But many people get liver or hepatic amoebiasis, amoebic abscess. Also may reach to the lung. Lung is nearby, may go beyond, they go to the brain. So remember, amoebic abscess, you may get them mainly extraintestinally in the liver, in the lung, and in the brain. The immunity is not proportional to the antibody formation. So if you have antibody, this does not make you protected against the infection. A trophozoite resists complement lysis. Cell-mediated immunity also involved and has a greater role than antibodies. Of course, cell-mediated, you have seen that we may get granulomas. And in the granuloma, the cell-mediated immunity is very important. Immunity in general, both antibodies and cell-mediated immunity provide a protection against recurrence. If you cure the patient, if you treat the patient to cure them, then this immunity can protect against recurrence. A clinical manifestation, you get diarrhea, as I said, intermittent. Foul smelling stool, as we mentioned with giardia yesterday. Flatulence, غازات بالبطن. Cramping abdominal pain. Ulceration, and this ulceration could lead to mucus and the blood in the stool, dysentery. The liver abscess, very important, usually in the right lobe. Why? Because the blood supply from the intestine mainly goes to the right lobe of the liver. It occurs in 5% of the cases. The abscess may extend to the surrounding tissue. For example, may rupture to the chest, may go to the lung, and so forth. Diagnosis, stool examination. As I said, we make 2 slides, wet preparation with normal saline and iodine stain, and you know why we make iodine stain. The most important thing is to differentiate between Entamoeba histolytica and Entamoeba dispar by the presence of RBC. Entamoeba histolytica contains RBC, while Entamoeba dispar has no RBC. ELISA to detect the stool antigen of Entamoeba in the stool. Serological diagnosis, we said we can detect antibodies. PCR for stool antigen. Extraintestinal antibodies detected in high level. For example, in extraintestinal, 90% of patients with extraintestinal amoebiasis, for example, in the liver, in the lung, has got antibody. So the antibodies are mainly present in these people. This is a case study, not case scenario. A student with 21 years went to Mexico. He got the infection, you can read it, and then he developed intestinal amoebiasis and spread to the liver, and he developed amoebic hepatic abscess. You can read the case scenario. The question, the diagnosis and answer of the above case study, diagnosis is supported by the detection of the Entamoeba histolytica in the stool, and also these patients, as we said, have got high antibodies in the serum. We said the extraintestinal have high antibody. So this case has been diagnosed with high antibody titer against Entamoeba histolytica. Treatment, we have non-invasive and invasive amoebiasis. If it is not invasive, paromomycin. Yesterday we mentioned paromomycin. It's aminoglycoside. Supportive fluid electrolyte replacement. If it is invasive ulcers and it goes down to the tissues, metronidazole and diloxanide. Remember, metronidazole and diloxanide. In very, very severe cases, there was an old treatment since many, many years ago, which is a broad spectrum antibiotic. You can add it also because we said secondary bacterial infection is common. You can add a broad spectrum antibiotic, and you know what's the meaning of a broad spectrum antibiotic. And you can use the old treatment, which is dihydroammetine, parenteral by injection. Especially it is used when you have extraintestinal amoebiasis, for example, hepatic amoebiasis. So in severe cases, you use broad spectrum antibiotic and dihydroammetine as injection. Remember, dihydroammetine. The prevention, of course, disposal of a human feces, because as we said, it is transmitted by fecal oral route. Improvement of personal hygiene, safe water drinking, awareness of sexual transmission. This amoebiasis also can be transmitted sexually. You have to remember it. And we said it is more present in immunocompromised patients. So you have to take care about immunocompromised patients. Any question?
دكتور
While it is a short lecture, you can ask about it, but it is very important. نعم.
بدي أسأل سؤال. حكينا إنه ممكن يصير عندنا infection بالimmune suppressed patient.
نعم.
حكينا آخر شيء إنه في الimmune suppression ممكن يصير عندنا infection. لازم إنه we must care about them. هلا if we treat them ممكن يصير recurrence ولا لا كونه ما عندهم immunity؟
لا، الريكرنس صعب إذا واحد اتعالج كويس وصار عنده immunity both antibodies and cell mediated immunity. الريكرنس صعب يصير.
even في الimmune suppression condition يعني
لا، الimmunosuppressed patient different story.
can be recurrent.
Immunosuppressed individual are more susceptible to get infection and to get recurrence
تمام.
because they don't have immunity, enough immunity.
Yes.
Logical.
دكتور بعد إذنك في عندي سؤال بالمحاضرات السابقة إذا في مجال. حكينا
نعم.
التريتمنت إنه الأنتي مايكروبيال are contraindicated، فشو السبب ما بقدر أستخدمهم؟
الانتيرو هيموريجيك ايكولاي بيها خاصية تعمل complications. حكينا على الهيموليتيك يوريميك سيندروم. اوكي، فلهذا السبب it's related to the complications of the ولهذا السبب الانتيبيوتيك لانه يعمل lysis of the microbe and cause release of the toxin of the microorganism, and this may lead to complications.
تمام دكتور.
نعم. Other questions?
يا دكتور
نعم.
من بعد إذنك عندي سؤال.
نعم. عين.
حكينا بالتريتمنت يعني ممكن نحط برود سبيكترم انتي بايوتيك.
نعم.
حضرتك حكيت بسبب السكندري انفكشن. طب
نعم.
ممكن يكون السبب ان بنحط الانتي بايوتيك عشان المايكرو فلورا بتساعد بالانفيسيفنس.
المايكروفلورا، انت صار عندك ألسرز. لو فرضنا هسه عندك ألسرز بالكولون.
تمام.
في بكتيريا بالكولون. هون البكتيريا تصبح وكأنما يعني disease causing، لأنه ما بقى عندك normal ميوكوزا. هذه commensal microbes إذا كانت الميوكوزا normal، بس إذا صارت الميوكوزا ulcerated, these microbes will invade the ulcers and will increase the susceptibility of perforation. واضح؟
واضح. بتصير باثوجينيك.
ولهذا السبب we have to use a broad spectrum antibiotic just to cover this point.
تمام. شكرا جزيلا
نعم.
دكتور.
عزيزي. Other questions? If not, we conclude this lecture and we hope to see you again, inshallah.